Welcome back. Today we're doing a deep dive into a procedure that really is a perfect lens through which to view the history of medicine itself, amputation.
It really is. It's this incredible journey from what was, a desperate, brutal trauma procedure
Right.
to the incredibly precise, planned, reconstructive surgery it is today. Our mission here is to get into the deep clinical judgment behind all of that.
Exactly. So for those of you in surgical training, this is for you. We want to extract the core insights, the things you need to understand to manage amputation stumps at, say, a conference level.
You're going to be focusing on the trade-offs. And I think the philosophy of why modern surgery is so completely focused on long-term prosthetic function.
We'll touch on the shocking history mortality rates up near 80%. We'll even talk about the surprising origin of the term guillotine.
And then we'll pivot hard into the modern stuff. Really systematic breakdown of anatomy, assessment, technique, and what actually makes for an ideal stump.
Okay, so we have to start at the beginning. Before the mid-19th century. I mean, before anesthesia, before any real concept of antisepsis.
It's a terrifying picture. The sources are just grim.
Yeah. For even the best military surgeons, amputation was a last resort that, frankly, often killed the patient anyway. You see these mortality rates of 30 to, 80%?
It's a staggering 80%. It's a crucial context to have. A patient could survive a catastrophic injury on the battlefield only to die from the surgery itself.
From what? Shock? Bleeding?
All of the above.
No.
Uncontrolled shock, massive hemorrhage, but overwhelmingly, sepsis. The surgeon's goal back then was singular.
Speed.
Just speed. That was the only metric of skill. Amputations had to be done with what historians call brutal efficiency.
Under a minute, right? Because the patient was awake.
Fully conscious, maybe given some wine or spirits, and then physically restrained by assistants. The whole thing was just an exercise in speed.
It's just an incredible philosophical shift, isn't it? Back then, success was just surviving the knife.
That's it. And today, success is measured in millimeters of a prosthetic fit, in decades of function. We went from a metric of speed to one of absolute precision.
And even if you survived that minute of horror on the table, you weren't out of the woods.
Not even close. The postoperative period was an absolute minefield of infection. We're talking gangrene, erysipelas, septicemia.
All fatal.
All fatal, long before antibiotics. And understanding that really highlights why every tiny detail of modern sterile technique is treated with such, reverence.
Okay, let's talk about a term that sounds purely historical, but it's not. It still has real clinical weight. The guillotine amputation.
Right. So surgically, a guillotine amputation is very specific. It's a rapid, circular, open amputation, all done at one single level.
And the key part is that it's left open.
That is the critical point. Closure is delayed. It's reserved for patients who are just too unstable, or, much more commonly today, when you're dealing with a really overwhelming infection.
Like gas gangrene or something.
Exactly. Severe necrotizing fasciitis. You get in, you excise all the dead and dying tissue quickly, you stabilize the patient, and only then, days later, do you even think about a formal closure.
The name, of course, everyone connects to the French Revolution, but there's a huge historical irony there.
A massive one. The physician whose name is on it, Dr. Joseph Ignace Guillotin, he was actually a reformer. He was arguing for a more humane, less cruel method of execution.
So he was a physician trying to minimize suffering.
Yes, and yet his name is forever tied to this device, and by extension to this idea of a rapid, brutal excision of tissue.
It's funny, the sources on the Revolution mention these tiny details being decisive, like nobles being identified because their hands were too soft.
Or their perfume. They wore these incredibly strong, rare oils that only the upper class could afford, and it literally gave them away.
That same attention to minute detail, whether it's perfume or the bevel on a bone, really connects that history to where we need to go now.
Absolutely. So let's make that shift. Let's get into the 21st century clinical judgment required here.
Okay, for a surgical trainee, this is key. When you're planning an amputation or just evaluating a stump, you have to think in layers. 5 essential anatomical components.
Right. And you can't just memorize them as a list.
Yeah.
You have to see them as this integrated system. You have skin, muscle, neurovascular bundles, fascia, and bone.
So if we look at that system, what's the most common failure point?
Yeah.
The one that most often ruins the chances of a good prosthetic fit later on.
It's often the muscle, specifically muscle imbalance and poor stabilization.
Really? More than the bone end?
I think so. I mean, yes, the bone end has to be smooth and the right length. That's non-negotiable. But if your muscle compartments aren't balanced and secured...
Through myodesis or myoplasty, which we'll get to.
Exactly. If you fail there, The muscles create these deforming forces. They create contractures, and they pull the fragile skin right over the sharp cut into the bone.
And that leads to breakdown.
It leads to chronic pressure, ulceration, pain, and ultimately revision surgery. A failure in muscle stabilization is a failure of the entire stump.
So, long before you even pick up a scalpel, the assessment and the history have to be just as rigorous. What are the questions that really move the needle from just a technically okay surgery to a truly successful outcome?
Okay, so we need to push beyond just the standard list of comorbidities. Of course, you need the primary disease process, the infection history.
Yeah.
You need to really dig into their pain. Is it residual limb pain? Is it neuroma? Is it phantom sensation?
But what's the underemphasized element?
I'd say it's two things: their mobility goals and their psychological preparedness.
Explain why psychological preparedness is a clinical metric. That sounds subjective.
Because it directly predicts outcomes. A patient's acceptance of the amputation, their willingness to push through the pain of early rehab, that dictates success. If they're not ready, we can do the most beautiful myodesis, and they'll just abandon rehab.
And then they develop a contracture.
A hip flexion contracture, and suddenly the stump is functionally useless. It's a massive predictor of failure that we have to assess up front.
Okay, so once you have that history, the physical exam has to be systematic. It's not just looking at a wound.
No, it's a structural engineering inspection. You're checking skin viability. Is it pliable? You're assessing the shape conicals, the gold standard. You have to physically palpate the bone end for sharp edges.
And what about neuromas?
You use Tinel's sign. You tap along the nerve paths to try and localize any potential neuroma. And critically, you check the range of motion in the joint right next door.
Because even a small contracture is a killer for prosthetic use.
It's a complete deal breaker. A minor flexion contracture fundamentally compromises everything you're trying to achieve.
All right, let's move into the OR, execution. Choosing the actual level of amputation. In cases of ischemia, this isn't subjective. It's all about data.
All about data.
Yeah.
We have to rely on tools that confirm perfusion right to the edge of the skin flap you're planning.
So what are we talking about?
We're talking about transcutaneous oxygen measurements, TCPO2 or skin perfusion pressure, SPP.
Yeah.
Clinical judgment is important, seeing the bleeding is important, but you need objective numbers.
And what's the number for TCPO2?
You want to see a reading above 40 millimeters of mercury to reliably predict that that flap is going to heal. Cutting too low to save length is a catastrophic error if the tissue isn't viable.
Okay, so let's talk flaps. Beyond the guillotine, which is for infection, most closures are flap amputations. What are the main designs?
The goal is always a tension-free, well-padded closure. For a below-knee amputation, a BKA, the workhorse is the long posterior flap, the Burgess flap.
Why posterior?
Because the calf muscle and the skin there have a much better blood supply. For the upper limb, though, or if you're really worried about tissue viability, you might use a symmetrical fishmouth incision, or even specialized skew flaps.
And what about a disarticulation?
That's where you go right through the joint itself. It preserves the maximal length, which can be really important in kids or for certain tumor resections.
Let's talk about the tourniquet. It feels like a surgical luxury, but it has rigid rules. When can you absolutely not use it?
The rule is pretty clear. You use it in clean elective cases. You avoid it in limbs with a severe established infection, especially gas gangrene, or in cases of really critical ischemia.
Why?
Because you risk pushing bacteria up into the systemic circulation, or you could push an already compromised limb past the point of no return. And you have to watch the clock. Under 90 minutes is the ideal.
And you always release it before closing.
Always. You must release it and check for complete hemostasis across the entire wound bed before you put in a single stitch.
Let's get really granular on a couple of technical steps. Nerve handling. How do you prevent a neuroma, which is just a devastating late complication?
This is such a high-yield detail. You can't just cut the nerve flesh. The technique is to pull the nerve gently but firmly, putting it under tension.
Okay.
Cut it cleanly with a sharp blade, and then release it. You have to let it retract way back, deep into the soft, unscarred muscle, far away from the bone and the future pressure of a prosthetic.
And what about the bone itself? It's not just sawing through it. Let's take a BKA. What's the mandatory modification you have to make?
Absolutely. So after you saw the bone, you have to deal with the sharp anterior edge of the tibia. It's incredibly vulnerable.
So you bevel it.
You must perform an anterior bevel. You file or saw that corner off at about a 45-degree angle. If you don't, you are guaranteeing that the skin flap will eventually break down over that sharp edge. It ensures failure and revision.
And let's revisit muscle stabilization one more time. Myodesis versus myoplasty. What's the clinical difference for a trainee?
Myodesis is the gold standard. You're anchoring the muscle and fascia directly to the bone itself, often through drill holes. It creates this incredibly stable, functional stump that can really drive a prosthesis.
But you can't always do it.
Right. It requires healthy bone and tissue. If that's compromised by infection or a tumor, you might be forced to fall back on a myoplasty. That's where you just sew opposing muscle groups to each other over the bone end.
So it's softer, but less stable.
Much less stable. It's a cushion, but it's not a functional anchor like myodesis. And making that choice is a core surgical judgment call.
Okay, procedure's done. Now it's all about healing and shaping. What are the options for dressings?
There are really three main types. You have simple soft dressings, which are just compression bandages. Then you have a rigid dressing, often a plaster shell, which is fantastic for controlling edema and protecting the stump.
And what about shrinkers?
Shrinker bandages come in later once the initial swelling is down. They are absolutely indispensable for getting that critical conical shape you need for the prosthetic socket.
So post-op, beyond pain control, what is the single biggest physio priority?
Preventing contractures immediately. The patient's natural position of comfort is flexion at the hip or knee.
And if that sets in?
If a patient develops even a small 15-degree flexion contracture at the knee, it's virtually impossible to fit them with a prosthesis. So it's aggressive positioning, extension exercises, and getting rehab involved on day one. It's mandatory.
And we have to watch for complications. How should we categorize those?
I think early and late is the best way. Early risks are things in the first few weeks. Infection, hematoma, flap necrosis, and of course DVT or PE.
And late.
Late are the chronic problems that ruin prosthetic use. Neuroma formation, those contractures we just talked about, skin breakdown, and painful bone spurs.
So this entire process, from that first psychological assessment to beveling the bone, it's all driving towards one thing: the ideal stump. Can you just list for us, what are the 5 defining features of success?
Okay, the ideal stump. 1, it has that conical shape for socket fit. 2, the scar is well healed, it's non-tender, and it's positioned away from any weight-bearing spots.
Makes sense.
3, it has excellent soft tissue padding and stable muscle coverage, hopefully from a myodesis. 4, the bone length is just right, a long enough lever arm, but not so long it interferes with the prosthetic components.
And number 5 has to be?
Full range of motion. The adjacent joint has to be free of any debilitating contractures. That's the goal.
This whole deep dive just shows the incredible arc of this procedure. From a 60-second race against death to a modern multidisciplinary process where success is measured in decades of mobility. It's just a remarkable story of surgical progress.
It is. And, we spent a lot of time on the technical details, the beveling, the nerve handling, the need for myodesis. But if you take a step back and you ask, what's the most common reason we fail to get that ideal stump today? It raises a really challenging question.
Which is?
Is the true limiting factor today really a failure of technical skill, a missed bevel, or a weak myoplasty? Or is it more often a failure to adequately address and optimize the patient's comorbidities, their nutrition, and maybe most importantly, their psychological readiness for the very long and difficult road of rehabilitation ahead?
A profound thought. It's about the partnership with the patient, not just the procedure, focusing on the person, not just the tissue. Thank you for joining us for this deep dive. Go forth and apply this knowledge, always prioritizing that long-term function for your patient.